So welcome to the World Health Network's Twitter space tonight, Politics Over Health, the Price of Lies. I'm Katie Marsh, your host. I'm so glad you're all able to join us in discussion. We've got an exciting ahead. I'm honored to welcome to the conversation our special guest tonight, physician scientist Dr. Ziad Al-Ali, Chief of Research and Education at the St. Louis VA and Director of Clinical Epidemiology at Washington University in St. Louis. Returning with us, welcome back Dina Parrish, best-selling author of the book Chronic, and our WHN co-founder and epidemiologist, Dr. Eric Feigelding, will be joining us shortly. So let's first just go over the format for the evening. We're going to have some discussion with our panelists, and then we're going to move to questions for the second half. I'll give everyone a heads up to request their question a little bit more into the program. So before we get started, let me first invite you to our website, www.worldhealthnetwork.global, and be sure to be following us on Twitter to get all of our latest updates and alerts. We welcome everyone to join our work and community, and you can easily do that by navigating to our homepage and clicking on our Join Us button. So tonight, we've gathered this panel together in response to President Biden's statement last week that the pandemic is over, and to further discuss the realities of COVID-19 pandemic. So let me give some context. Biden made a campaign promise to tell the truth, to listen to the experts, and always put health and safety first, no matter the political cost. But here we are looking at what Biden said last week, which is a huge misrepresentation of the state of the pandemic. The pandemic is certainly not over. So many are sick, they're suffering from long COVID, and they're worried about the ongoing accumulation of disability and the new variants that are further undermining immunity, which we'll be talking about later. So first, we'll start with physician scientist, Dr. Ziad Al-Ali. So pleased you could join us tonight. Could you tell us a little bit about your background and how you got into COVID research?
Sure. Well, thank you for having me. I'm a clinical epidemiologist and also a physician, a nephrologist by training, a kidney doctor by training. And at the very beginning of the pandemic, we gathered virtually, actually, around a Zoom call, myself and my team, and started thinking about how can we do our part to really help address the challenges of the pandemic. We knew it was happening. We knew something big is happening, but we didn't know at that point, there was really anything called long COVID. But we resolved at the beginning of the pandemic to really use our tools and expertise with data and clinical epidemiology to identify questions that are really important to the public and address them using rigorous methodologies. And then one thing led to another, and really started sort of getting reports from patient and patient advocacy groups that everybody was telling them at that time, that was in April and May of 2020, that you get COVID, and if you're young and healthy, you bounce back in a week or maybe two, and then it will all be over, and you get over it 100%. But they were not getting over it 100%. A lot of them were having lingering problems, including headaches and brain fog and fatigue and several other problems. So that was really our aha moment, that something was happening there. That the virus that everybody at the time was telling us is an acute virus. You get it for a week or two and you get over it and I'll be fine. It's actually not fine for a lot of people and results in lingering problems. So we decided at that point to pursue long COVID, and it was really a new area of investigation for us. But over the past 2 years and a half, I feel we sort of made significant progress in helping us and the world understand what long COVID is.
All right, great. And recently you had a new study published in Nature about the neurologic effects of COVID. Would you like to start off by talking a little bit about the results of that study? That's been on folks' minds.
Sure. So that was in Nature Medicine and was published about 10 days ago. So in that paper, we knew that people with COVID-19 can go on to develop what people refer to as brain fog, sort of a cognitive impairment that is colloquially referred to as brain fog. But we didn't know if really COVID can result in neurologic manifestations outside of that. So we decided to take a comprehensive look. We built a cohort about 150,000 people with COVID-19, and then two control groups of nearly 11 million people who did not have COVID-19. And we followed them for a year. What we saw that people with 19 had an increased risk of several neurologic problems, including strokes, again, memory problems, peripheral nervous system disorders, seizures, headaches, So inflammation of the brain, inflammation of the peripheral nerves, autonomic nervous system problem, or dysautonomia. A lot of people on the call today or in the Twitter space today will actually recognize this, the word dysautonomia or disorders of the autonomic nervous system. So it's really much more than just brain fog. In the public consciousness, long COVID is brain fog and fatigue. It's really much more denser than that and can result in a variety of neurologic problems. What we also found, and that's really, I think, is really very important to note here, is that the risk was, this increases according to the severity of the acute infection, meaning that people who had really bad, severe disease initially get the highest risk. But, and it's really an important nuance here that gets missed a lot, the risk was evident, was clear as the sun in people who did not have severe disease. And why this is really important? This is really important because these are the people who represent the majority of people with COVID-19. Most people with COVID-19 don't need to be hospitalized for it. Most people with COVID-19 have really mild illness initially, and in some cases, asymptomatic illness, meaning that they really don't have any symptoms at all. And then 2, 3, 4 months later, they come down with that stroke, start having seizures or intractable headaches, or they can't remember where they put their keys and have all this brain fog and memory problems. So, and it's this is a very, very, very important group because really, again, it really represents the lion's share of people with COVID-19 in the US, around the world, are actually either asymptomatic or have mild disease. So even in people with mild disease, they can certainly come down and get all these neurologic sequelae.
Great. And I know that you had done some research also on the cardiac effects. Would you be able to share about that?
Sure. Using the same design, we also looked about the long-term cardiovascular manifestations of COVID-19, and similarly, we see that the virus can result in long-term manifestations not only in the brain, not only neurologic, but certainly cardiovascular. And people have myocardial infarction or a lot of dysrhythmias or abnormal rhythms of the heart. Either their heart rate is too fast, beating very, very quickly and too fast, or in some cases really too slow. And a variety of other heart problems. And I think what really this tells us about virus is that it's really this is not a virus this is not sort of a virus that we can just ignore. I mean, it's certainly in some cases, and everybody, 100 people, maybe a lot of people are actually just fine, but in some cases can result in serious long-term consequences in the heart, in the kidneys, in the brain, and a variety of other organs.
Exactly. Yeah. So I know that some people feel that if they take the vaccine, or they've been told, the messaging has been a bit confusing, right? If you take the vaccine, does that keep you safe? Does that keep you safe from long COVID? Does that keep you safe from infection? And I know that you've looked into that as well. Can you speak on that?
Absolutely. So vaccines do a really wonderful job reducing the risk of hospitalization and death in the acute phase. And what they were designed for. We designed the vaccines to reduce the severity of the disease initially. So what they really do a wonderful job reducing hospitalization and death. But they don't do very well at really protecting us from long COVID. So vaccines really reduce a little bit the risk of long COVID, but do not eliminate the risk of long COVID altogether. And I think sort of people ask me like why, and I sort of generally give the example of a if you've trained all your life to run or if you're an athlete and trained all your life to run 100 yard and now all of a sudden we're asking you to run a marathon, it's unlikely you're going to be able to really run that marathon and also win gold, right? If you're an Olympian and you maximize and you really done your best to do 100 yards really, really, really well, you don't necessarily really perform very well in the long haul. The vaccines that we have right now were really designed 2.5 years ago when we did not even know that long COVID existed. The word long COVID did not even exist in our public consciousness. If I had told you more than 2.5 years ago long COVID, you would have said, "What is that? What are you talking about? I don't even know what that means," right? So it was not even in our public consciousness, in our brain. So now that we know that long COVID exists, and we know that this virus can produce or can result in long-term manifestations, we really need to up our game and redesign or reconfigure our vaccine strategy. So vaccines are designed from the get-go to not only reduce the severity of the problem in the acute phase, but also reduce the risk substantially and significantly reduce the risk of the long COVID, which they don't do very well right now. They do a little bit of risk reduction, but not really substantial.
Yeah, exactly. And we're also wondering about multiple infections. I mean, with mask mandates being brought down virtually everywhere, and the CDC guidance for 5 days staying home, people are going back to work. even when they're still infectious. Kids are back to school when they're infectious, and there's so much transmission is happening. So it's inevitable, right, that the whole public system is going to be exposed. So what's happening with the cumulative effects of repeated infection after infection? Does it help you to not get it again if you've just had it, or like what's going on there? Because this is confusing.
Yeah, thank you for this. This is really actually a very, very important question for actually, because unfortunately for a lot of Americans, they've already gotten one infection. In some cases, they've gotten two infections or even three. So the question of protecting themselves from the very first infection is already a moot point. Now, for them, really, the question is, does it really matter? Should I really exercise that vigilance and do my best to protect myself and my family from the second infection, or even in people who got two infections already, the third infection? And the answer is absolutely yes. So we looked at this in a scientific way to evaluate the risk of having a second infection versus no second infection. And what we really found is that getting that second infection adds risk, meaning that you're buying yourself additional risk if you're exposing yourself to the second infection. What that really translates to, that if you're now on Twitter Space, sitting at home or somewhere else and listening to this, it's very, very, we feel it's very, very important to still protect yourself from that second infection, that third infection. And a lot of people tell me, well, like, I got it, or I'm hearing that the second infection is milder than the first one. Or maybe my body, because I've had one infection, now and I've been vaccinated, quote unquote, I'm super immune. And I think that's really ignores the fact that the virus is mutating, and ignores the fact that it may have gotten Delta, or maybe a sort of a prior strain, or even Omicron, or like several months ago. The virus that's circulating now is also likely to continue to circulate or evolve. Is going to be very, very, very different. And even if your body, you're saying, "Oh, I've seen this virus before, I know how to deal with it," it's still absolutely worth it to protect yourself from that second or third infection.
Yeah, absolutely. I actually had a friend who had COVID 6 weeks after I had COVID. And the second time around was so much worse. They were really surprised because they thought the first time wasn't so bad, right? Because that's what people think. Oh, I did it. I already had it. It wasn't so bad. If I get it again, no big deal. But the second time around, it really floored this person to the point where they thought maybe they would need to get medical help. So.
This is very, very important, but also true that in some cases it could be milder. In some cases it could be the second one is milder. But I give people sort of the example of a house fire. It's like, okay, you've had a house fire the first time, and now you responded to it, so you develop that expertise to really fight the fire and put it down. You don't go say to your spouse, "Hey, honey, I know I'm very, very good at putting the fire out. Let's start a second one." And maybe because you're good at putting the fire out, the second time around, you're going to be able to control it better and deal with it better. The same way, maybe your body will say, well, I've seen Omicron before. I know how to deal with it better now. But it's far better not to have that fire in the house in the first place. You don't really say to yourself, well, like, I'm very good at putting the fire out now, so let's go start another one because I'm so good at it. So even in the instance or the example where the immune system has seen the same virus before, which may be unlikely because the virus is mutating, but let's assume, you've seen the same virus before and now you're able to deal with it. It's really, sort of almost like starting that fire again. And on the assumption that you're going to know how to deal with it better the second time around. Well, what's better than that and safer than that is not to start the fire in the first place. So what's absolutely safer than that is really to try to reduce your risk of getting exposed to that virus again and encountering that chance of getting long COVID.
Yeah, it sounds like it's just avoid it. Bottom line.
We think it's very, very important. Yes, we think it's very, very important. We think people need to also understand that getting COVID-19 is not really a matter of dealing with it in the acute phase. A lot of people actually, you could deal with having sore throat or fever or a headache for a day or two or three or four. What really most worries me is really the prospect or the potential or the likelihood of getting long-term manifestations or long-term consequences as a result of the first infection. Even though in some cases, as we just said, you could be asymptomatic or mildly symptomatic, but then still end up with long-term consequences. That's really the scary prospect for and I think people need to sort of think about COVID, not only that you can get sore throat for a day or two or three, but in some instances, that SARS-CoV-2 infection could actually lead to long-term manifestations that for some people will scar them for life. For some people, these long-term manifestations may actually last with them for a lifetime. And that's really certainly, in my way of risk tolerance, is certainly something that need to be avoided.
Yeah, absolutely. We've seen that. We've had guests on that have talked about just devastating health long-term effects, they're not sure if or how they will relieve themselves. Dana.
So, Dr. Ali, I'm so pleased to finally be able to talk to you like this because I am a really big fan of your work and so appreciative of everything that you're doing. And thank you always to WHN for having me. I love being part of this group. So, I mean, I'm listening to you and I just can't help but wanting to talk about how people can block infection. You know, there's a lot of exhaustion. I'm exhausted too. I know you're exhausted. We're all tired of this nonsense. But given all that your data has borne out, all of these complications in mild and asymptomatic cases, and in worse cases, obviously, and also in young, healthy people, don't you think that we should be also uh, really trying to avoid infection, like good ventilation? You know, nobody's really talking about indoor air quality. People don't want to wear N95s, but I, more than not wanting to wear an N95, I don't want to be saddled with these problems. You know, I've had really bad, severe Lyme that caused me heart failure. I don't need to go to that party ever again. And I don't understand why there's such a resistance to the reality of just accepting that this is actually really happening. It's really true. I mean, how do you protect yourself? I'm curious if you've been infected before, how you, and you know, how you did if you were, and anything you're willing to share.
So yeah, well, thank you for this. So thankfully, I haven't had sort of SARS-CoV-2 or COVID-19. So that's really thank God. But I do think that the in the long run, we really need to protecting the public en masse will need to be a multi-pronged strategy. So one of them is really certainly masking. I mean, to sort of feel that dropping mask mandates and sort of the reluctance by some to really embrace the simple act of masking, which is really very sort of minimal to protect oneself and other people around you, especially people who are immunocompromised. You could be actually literally walking right next to you at the grocery store. So it's not only about you, it's about also protecting your community. And not everyone has really strong and wonderful immune system. There are some people out there with cancer on chemotherapy, et cetera, who could be like at that grocery store right next to you in the aisle, shopping for their family or trying to do their trying to so the simple act of masking and as you just discussed also, like ventilation is very, 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 very important. And but even more than that, I really think that our current vaccine strategy or the current vaccines don't really do very well in reducing the risk of transmission or reducing the risk of getting the virus.
Right.
And they're actually designed to reduce the risk of severe disease. But and I do think that we really need to up our game and introduce either nasal vaccines or vaccines that really boost or produce mucosal immunity to really reduce that risk of transmission. So we cannot. It has to be multi-pronged. We cannot rely on indoor ventilation alone. We cannot rely on masking alone. It has to be multi-layer, multi-pronged approach. Some individual responsibilities, some state responsibility, some federal responsibility, and also an updated vaccine strategies that really take into consideration the fact that we really, really need to block transmission. We need to reduce that risk, and we cannot rely on only one layer of protection alone. And fortunately, the science exists for intranasal vaccines, and people have called for sort of boosting federal funding to accelerate the development of those vaccines. Actually, two of them were approved in China and in India. So those things actually exist. Those things actually have been approved in other countries. We're lagging behind, and I think it behooves us as a society, as a community, as a in the U.S. here to try to accelerate progress along that line, because that's going to be a sustainable long-term strategy to reduce the risk of contacting the virus in the first place.
Totally agree with you. And this is not a sustainable strategy. What we're doing right now, which is nothing, is not a sustainable strategy. And I'm extremely concerned about dropping masking in healthcare situations, in healthcare settings, in nursing homes. I kind of saw the writing on the wall because I saw some op-eds being written a few weeks ago saying, let's drop masking and for healthcare workers. And I thought, oh God, here it comes. Get all your doctor's appointments over. It's really it's just very disturbing to be living in a world that you feel unsafe just doing basic things. And you should feel safe to go to the doctor and not have to worry about coming home with an airborne, organ destroying virus. I just think it's horrible. Do you know anything much about the nasal vaccines at this point in the other countries? I don't. So I know that they exist, but how effective do you think they are? Do you have any feelings about that yet?
We don't have a lot of data yet. But actually, so the Chinese did not release their data, so we don't really have that data yet. And I'm not really very familiar with also the one in India. But we know scientifically here, like from data accessible to us in the US, we know that technology exists. We know it's sort of really is not even it's really advanced enough, sufficiently advanced that if there is not enough federal funding to sort of boost or accelerate its development, we can certainly have intranasal vaccines here to boost mucosal immunity and substantially reduce the risk of transmission, cut that chain, reduce sort of the chain of transmission, in no time. And people have called for, like sort of a operational nasal warp speed, or like I don't know what they called it, but it really we feel this is really that absolutely on the right track there, and trying to accelerate progress of intranasal vaccines or vaccines that produce substantial mucosal immunity to reduce that risk of transmission.
I can't agree with you more. And also, if we want to talk about Operation Warp Speed, we need to talk about early treatment. There needs to be antiviral warp speed. We need trials for antivirals for long COVID, don't you think?
Oh, absolutely. So I think one of the silver lining of this pandemic is that we've developed, like the first generation of vaccines very, very quickly in Operation Warp Speed. Now we have Paxlovid, Molnupiravir. We have antivirals that are actually, quite effective in reducing, again, risk of hospitalization and death in the acute phase. What we don't know, and it's really a huge knowledge gap, is whether those same antivirals, Molnupiravir or Paxlovid is much more commonly used, really actually reduce the risk of long COVID. There is really an urgent need to really to understand this, because if it really does, in early treatment, in the very early first few days of the infection, typically in the first 5 days of the infection, treatment with that antiviral, if that really abrogates or reduces substantially the risk of long COVID, that we need to know this yesterday. That's very important. So I think that I think that Pfizer bear a huge responsibility here. This is their drug, and the U.S. government, bears the responsibility to try to make sure we're moving in that direction as soon as possible. There are a lot more cases of long COVID could be avoided if that really works. Indeed, a lot more cases of long COVID could actually be avoided, if we know this information now, and actually increase uptake of Paxlovid use in the U.S.
And there must be other. Oh, go ahead, Katie. Sorry.
I just had a concern actually about another vaccine hopeful solution because of variants changing. So is the technology with mucosal vaccine somehow superior, that it is going to be robust against the virus constantly changing? Are we going to just be chasing our tail again with another type?
This is absolutely brilliant, Katie. Absolutely, this is really wonderful. I discussed one aspect of the vaccine strategy. We really need a vaccine strategy that hits four things. First, we need more durable vaccines. Let's face it. I think all of us know that the statistics and the data. A lot of people got their first dose. Much like the number of people got the second dose is less. The first booster, the second booster is less and less and less. So people are really, sick and tired of having to get boosters every 6 months. So we need vaccines that result in more durable immunity. So the frequency of getting vaccinated would need to be less to really encourage that uptake by the public. Two, we need the pan-coronavirus vaccine, meaning that, or a variant-proof vaccine, meaning that exactly we don't want to keep chasing our tails. We've learned about COVID-19 so far, or SARS-CoV-2 so far, is actually, really the constant fact in this whole thing is that it keeps mutating. Like last summer, we were talking about Delta. We were all talking about Delta. Like, guess what? We're talking about Omicron now. Not even Omicron, BA.5, and now actually, other variants or sub-variants on the horizon. So the one constant in this virus is that it continuously is evolving, and designing a vaccine for BA.5 or BA.4, that's really looking in the rearview mirror. The vaccine is, and the virus is really ahead of us. So I think we need to up our game and really use or develop what we call variant-proof vaccine or pan-coronavirus, vaccine. Three, we really need a vaccine that protects us against long COVID. And that's really very, very important. And I think that's really, and four is what we just said, is really a vaccine that actually block transmission. So these are four pillars or four criteria for a really robust vaccine development strategies. And they may not all come in one vaccine. It may be that people need to take, get the shot and the intranasal, vaccine. So dual vaccines that cover these four pillars and will provide durable immunity against a bunch of viruses or a bunch of SARS-CoV-2 variants, not only one or two or three, but a lot, sort of cover a broad spectrum, again, durable, protect against long COVID, and also reduce the risk of transmission. So those four pillars are very, 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 very important in considering our updated vaccine strategy. And we really need to accelerate progress in that direction. This is really, we really should not have to wait 10 years to get to this point, to get a vaccine strategy that really satisfies these four pillars. We need this yesterday. And so we really need an Operation Warp Speed 2.0 to really get us there, maybe in a year or two. Because if we don't do this, if we don't do Operation Warp Speed 2.0, we will get there in 10 years, and a lot of us would for a lot of us would be actually too late.
I think you should also, if you don't mind, just talking about. I mean, we're coming in knowing that there's viral reservoirs, but I think a lot of people that are listening may not know what are the possible causes of long COVID, and we should talk about these privileged spaces in the body that can be harboring the virus long after your acute infection is gone.
This is very, very important. So one was the leading, so people ask me a lot, like, so why do some people have long COVID? So what's sort of mechanism, what's the biologic mechanism that actually explains why some people get long COVID? And the short answer, we don't completely understand. Like, we don't really, that's the short answer. We don't really know it all at this point. Absolutely not. But our leading hypotheses or sort of leading theories that explain why some people may go on to develop these long-term manifestations, fatigue, brain fog, heart problems, kidney problems, et cetera, et cetera. And the leading hypothesis is that the virus, in some people, that's not everybody, most people would just clear the virus and do just fine.
Do you think so? Do you think most people clear the virus?
Well, I mean, the people who don't really develop long-term manifestations do clear the virus. I mean, right? I mean, we have no evidence.
When do we know? Like, how long do we know? Because I know there's the latency. I don't know if you want to call it latency, but I hear from people like they're fine, and then 2 months later something happens, or as you had said, like you can have a stroke.
So this is very, very important. So actually there is a study coming out soon. I don't know if I'm like by a large group at NIH actually doing sort of a very nice study. So I don't want to talk about it too much now because sort of I don't want to scoop them, but sort of chronological, sort of giving us a window into the temporality of how the viral persistence in the bodies of these people and in different organs. But I think it's safe to say that one of the leading theories or hypotheses is that the virus might persist in some people, and then that virus, and it does not have to be the full virus. It can actually be of it, either RNA fragment or protein fragment. So basically, small pieces of the virus may not be the whole virus, but it persists in some people for a period of time, and that then provoke in the body, sort of a reaction or low-grade
inflammatory,
or inflammation that then sort of results in organ damage, result in heart tissue damage or brain tissue damage or kidney tissue damage, et cetera, and then resulting in that sequela. And that's really a very, very viable hypothesis. There's been a lot of work that have been done by a lot of people to sort of investigate this, and and a lot of the evidence actually points in that direction. I would not say at this point really conclusively 100% that we have conclusive 100% evident this is exactly what's happening, but it really certainly sort of the constellation of evidence put together points in that direction, highly suggests that this is really maybe happening. Yep. And that's why our emphasis when we talk about Paxlovid and doing trials on antivirals, because if the problem is that the virus is persisting in immune privileged sites, then one of the ways to really try to address that is really antivirals, right? Like what do antivirals do? Really, sort of attack the virus or preventing from copying itself, or like making more copies or more clones, of itself. And that's really why we feel it's very, 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 very important to really do those trials as soon as possible to really learn what works and what doesn't, right? Like that's how we do in science. Like we don't know if this is going to work or not, but the only way to know is actually to do the experiment and then learn from it. And it might work, which would be great. If it doesn't, it also teaches us a lot. It's like, oh, well, this doesn't work, maybe. And then we start thinking, okay, well, if this pathway doesn't work, what other pathways could be plausible to pursue, right? Yeah. So and without doing that, we're not going to learn. We're not going to know enough to really, progress in our fight against COVID and long COVID. So that's really an essential piece of information that we really need. And the only way to know it is to do the experiment, or in this case would be the trials. And if we don't do those trials, we're not going to find out the answers.
Absolutely.
And in our view, this needs to be happening yesterday. We definitely need those experiments or those trials to be done as soon as possible.
Right. And science and medicine, it needs time. And in the meantime, we are just letting this virus rip through, and the variants are just changing so fast. And that is just really concerning to me. Like, our society, cannot withstand so many people getting more and more disabled. Like, we already have a workforce problem. We already see that for ourselves. We go to the store, their hours are reduced, we can't get service, there's not enough doctors, there's not enough nurses. Like, things are getting bad. We can't afford, and it's true, science and medicine just takes time and to be thorough, because you want your medicine to be safe.
Yeah, definitely. But there's also a sense of urgency, right? So yes, we definitely have an obligation to be thorough and complete. But it doesn't also mean that we cannot really if it's an all hands on deck situation, and there's urgency behind it to sort of try to accelerate that progress to the extent possible without sacrificing rigor. And there's a way to do that. I mean, obviously we could do that, and this needs to be marshaling those resources toward a common goal of getting that updated vaccine strategy, of discovering whether or trialing or testing Paxlovid or other antivirals to try to figure out if those are going to work or not. And I think that's very, 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 very important. And it's really very important it's done as soon as possible to really help us, help or equip us with even, more tools to really fight COVID and long COVID.
I totally agree with you. I'm so appreciative of you talking about the persistence aspect of it, because I think it's so important to bring that to light. I just I don't know how to get the message out any more clearly than somebody like you talking about what we're seeing. And there's about 300 studies now on pathogen persistence, and that's just COVID. And then we have COVID activating other infections that need treatment and other infections that need to be evaluated for. So these are all things that are extremely important on the long COVID landscape. And I don't know how to be more emphatic about it. All these things need to be addressed.
Yeah, absolutely. I'd like to introduce Yanir Baryam, co-founder of the JBOHN. Would you like to comment on this one?
So, yes, thank you. I mean, I think I had a conversation with a friend today who I hadn't spoken to since maybe early in the pandemic. And it really struck me how important has been the research that Ziad has done, because it really informed the conversation that I had with this friend, because I was able to tell them that the story that many people have said, that is often assumed, that that at this point people are not getting severely infected, or that if they got infected they won't get reinfected, or if they got reinfected it wouldn't be severe, and I was able to let them know that that's just not true. That there are severe neurologic effects, there are severe cardiac effects that happen even for people who are having mild initial cases, which has been really the focus of discussion. And I was able to tell them that if they get reinfected, it's not that they won't have the effect. In fact, there's a cumulative harm that is happening that Ziad has demonstrated dramatically in the research, that the second infection, the third infection, are not milder. They may even be more severe in their long-term consequences than the first infection, and that cumulative damage is quite important. Now we've been talking about the importance of the variants and how that's affecting the vaccines. But part of the opportunity that we have is if we reduce transmission, then the variants don't happen so fast. So if we do things like masking and ventilation and testing and the social distancing that we're able to do, we actually gain both ways. We gain by preventing the infections, but we also slow down the variants so that we have better vaccines. So if we develop a new vaccine, it won't be undermined. And that will enable us to combine the tools in a much more powerful way. And this all became very clear when I was talking with his friend, and he was very appreciative of my explaining this to him, because he had been told, he had been led to believe that we didn't have to be worried about what was going on. And he understands that if, in fact, these consequences are present, he really wants to know this. He was very appreciative because he wants to take the precautions that are needed to protect his children and his family from these kinds of consequences. So I think that that's a super powerful message that Ziad has built through multiple research efforts that we really have to take into the policy understanding. We have an opportunity to prevent very severe outcomes of many, many people. And the way to do that is to combine these different methods for both reducing transmission and then being effective at combining them means that we can really reduce dramatically what's going on in terms of harm.
Thank you. Does Dana, do you have anything else you want to bring up with us tonight?
Well, since we are talking about misinformation and disinformation in the public domain and things that need to be cleared up, one thing I wanted to talk about, if it's okay, is what just happened with my dad, because I think it's a really instructive story. My dad was vaccinated with 4 vaccines, Pfizer vaccines, and he wears an N95 indoors all the time because I'm his daughter and I drive him crazy. And so does my mom. And to our knowledge, none of them hadn't COVID so far. And about 5 weeks ago, my dad and mom went out with some friends for dinner, and they had just gotten out of quarantine. They both had COVID, and my parents did not think to ask how many days. They didn't really, it didn't occur to them they would still be contagious because they were out of quarantine with CDC guidance. And lo and behold, my father, 48 hours later, had 103 fever. His blood pressure was 200 over 95, and it was incredibly frightening. He's healthy and he's active and he still works and he still runs around, and he is not immune compromised. And he would have had to be hospitalized, except that when I called the hospital, I spoke to a nurse and she told me off the record, I wouldn't bring my dad here if I were you, unless his oxygen drops below 90. We are slammed. He won't get good care. And if you have a good doctor that can oversee his care at home, which we did, thankfully, my doctor, because his primary care doctor wasn't even really available. And so, just getting like the drugs that he needed, just getting the care that he needed at home, having to have my mom constantly taking his blood pressure, his oxygen level, his pulse, his temperature. It was an incredibly harrowing couple of weeks. And he took Paxlovid. He took took everything published to work for COVID, essentially. And, he's extremely fatigued. But I think that even my parents didn't believe that they had just been boosted about 5 to 6 weeks prior. They had their 4th vaccine about 5 to 6 weeks prior to him getting infected. And I think even with all of my ranting and raving, it's still really difficult to overcome what they hear on the news and what they see in the newspaper, which is, I hate this. I hate all these phrases like vax and relax. Like I want to vomit because it's just completely PR spin, and it's just really misleading. And there's so many terms that people are using that are, for example, post-viral, post-infectious. We should call things infection mediated probably, because it's really not necessarily post-infectious. All these things inform our understanding of what's going on with our bodies, what our clinicians understanding how to treat us and how to think about us. And it informs our risk going out into the world. I think that it should really stop. I think we should stop pretending that, you can't get released for being vaccinated to the fullest and you can't have a really bad outcome. I think that's incredibly unfair. And I'm personally, it happened in my family. And it's also happened to other people in my family and other people that I know. But, it's my dad, and I'm really angry. He was subject to this kind of messaging, and he was also subject to these terrible guidelines by the CDC, which, most people are still infectious at 5 days. Most people are still contagious at 5 days. I think it's like 2/3. I'll let Dr. Al-Ali or Yanir tell me if that's the correct stat, but we know it's a very, very high number. My dad was positive, by the way, for about 17 days. So that's with all the vaccines and Paxlovid. That's very, very disturbing. And, luckily, and how much money did we have to spend personally to get him all these tests and make sure that he tested out of quarantine and all these extra supplements and make sure he had vitamin D at home and a blood pressure monitor and a pulse oxygen meter, a pulse oximeter. It was hundreds of dollars just to do the basics. And it's really, really wrong that we have to spend so much of our own money on keeping ourselves like alive and safe when this thing is being allowed to run rampant. through society with all of its misinformation carried along with it. It's just not okay.
No, Dana, it's really not okay, and there's so many people that are not in a position to be able to negotiate extra time off, even if they do know better, and they're not being given the right guidance. And like you said, all this out-of-pocket cost and time lost at work, or time going into and feeling awful and maybe getting sicker or what have you and spreading it. I mean, it's just a really bad situation right now.
And wearing the wrong mask. I'm so sorry to interrupt you, Katie. I don't want to forget to say this because there's a lot of misinformation about masks. And I hate that this is political. Virus doesn't care what you believe in, who your God is, what your politician of choice is. It doesn't matter, okay? If you don't wear a mask that is going to block the infection, like an N95, like an elastomeric, you are going to be subject to both spreading the virus if you have it. So cloth mask, a surgical mask, they are not enough with this kind of an airborne virus. And you are also going to be subject to getting infected and reinfected. So, I mean, the scientists that I know, that I trust, and the physicians that I know, that I trust, they completely adhere to this. This is not a secret. This should be on the table, and you should at least have the right to know the truth about what is going to protect you and what is not. It is not as simple as wearing a mask. Many masks do not work well enough to protect you or others if you are infected. So I just have to say that and make it clear. I still think there's a lot of misinformation about this in the public domain.
Yeah, absolutely. Yeah, so I think we're going to open up for some questions. We are still expecting Dr. Eric Feigelding to join us this evening. So we will start, we'll just take one question at a time. If you could please be brief with your questions so we can get to as many as possible. We'll start with Professor Sunat. Looks like you're connecting. Here we go. Hello. Go ahead, Professor. All right, perhaps there's a tech problem there. Daniel, would you like to ask a question? Looks like there might be some technical difficulty here. Well, let's go to...
I think they have to also, after they connect, they still have to push on the speaker button.
Yeah.
Yeah, may I?
Oh, okay. We can hear you, Professor Sunit. Please go ahead with your question.
Yeah. So thank you. So I was listening very carefully. I am having two issues here. Like the one, we agree to it that vaccines are protective, at least from severe disease. But when we use the term severe disease, it should not always be correlated with the mortality, but long COVID itself results into the disability adjusted life years in terms of the brain fog and all of a sudden myocardial infarction and these issues, even as you discuss this fatigueness, which is a really terrible. Means you start your day for working and you are sitting in a office half-heartedly doing some work and most of the time you are idle. So this is something very concerning, number one. Number two, when we say, I think previous expert was saying that pathogen is lying somewhere in immune privilege site. So what do we mean? We are going closer to the HIV, where HIV is lying latently for years and years, and gives jerks when person suffers from some immune suppressed condition. So just I want to have comments on these 2 points. Thank you.
Thank you.
I can Katie, I can address this. So thank you for the question. And in terms of number one, I mean, definitely your first part of your question, definitely agree that vaccines do reduce risk of severe disease, and that does not include only death, but also include hospitalization in the acute phase. But when we talking about severe disease in this case, we're really limited to the acute phase. And I definitely agree with you that long COVID in some cases could be severe and disabling, and some of the consequences of long COVID are really, will scar people for a lifetime. So that certainly is severe disease. And what we know now about the vaccines is that they reduce a little bit the risk of long COVID, but the risk reduction is not really sufficient. So, and by that I mean that reliance on vaccines as a sole mitigation strategy for long COVID is really not a sufficient or a really a good long-term strategy. We need additional layers of protection in addition to our current vaccine. So we definitely feel on the same page there. And what we definitely did not mean to say that long COVID is not a severe disease. It just certainly in some cases it could be severe, disabling, and really sort of affect people for a lifetime. And in the second part of your question, I think the hypothesis for viral persistence is really it still remains a hypothesis. We're learning about this as we go. And there may be some, at this point, I don't really know if this is really going to be, it's definitely unlikely to be like HIV, exactly like HIV. So it certainly would be, different sort of a different mechanism, but I think we have to caveat this by saying that we're still still sort of scratching the surface in developing our understanding of whether there is really truly indeed viral persistence and that mediates long COVID, or maybe there's something else. And I think I certainly subscribe to the idea that there's viral persistence, and I think we're learning more and more about it. But to sort of analyze it or draw parallels to HIV at this point, I think would be we would be sort of overstepping the science at this stage of the game. And certainly need to be more work done to help us understand exactly how and why and in what situation sort of a viral persistence exists, and how much of that is really mediating the long-term sequela versus potentially other mechanisms here, like sort of other mechanism, maybe subtle injuries at the acute phase and may sort of cascade and become much bigger problem downstream, or microbiome hypothesis. I mean, there's a lot of other hypotheses other than the viral persistence.
If I can just add a bit, because you said something that was very significant. You said the long-term consequences can affect people for a lifetime. But your research also comes in a context where, again, we talk about the severity of the disease in terms of death and hospitalization. The death rate in the acute phase was originally between 1% and 2%. And then people had debates about it. From your research, the death rate from the sequela, from the long-term part, even over 6 months, is between 1% and 2%. So it's not just the fact that people live with this for a lifetime. Their lifetime may be very short because of these long-term consequences. Maybe you would like to comment on that.
Absolutely, I agree. So definitely we see certainly death in the acute phase, that's in the first 30 days, but we certainly see also increased risk of death in the post-acute phase. And that's really very, very, very evident. And in addition to that, we also see some of the sequelae, like heart failure or heart attacks or stroke. These in by themselves, they're long-term consequences that are associated with reduced life expectancy. So there is really, we're certainly on the same page there, that SARS-CoV-2 does not really only result or lead to increase in acute mortality, but certainly in the post-acute and long-term phase, people with SARS-CoV-2 infection have a higher risk of death in the post-acute and the long-term phase. Absolutely true.
Thank you. We're going to move to socially awkward, and then Dr. Benjamin Matthias. Go ahead.
Hi, yes. Is Novavax a pan-coronavirus vaccine?
Who would like to take that? And thank you for your question.
Maybe the short answer here is really not, and I think we definitely need sort of to evolve the mRNA vaccine strategy to be a pan-coronavirus vaccine strategy.
All right, thank you. Eric Feigelding, welcome. Thanks for joining us tonight, co-founder of World Health Network. So how are you doing today?
Hey, everyone. Good. Sorry, I'm joining a little bit late. Also, the Novavax is a very good question, by the way, because there is discussions that in some of the studies do show it has broader variant coverage and protection than just the mRNA the original mRNA, not the bivalent ones, but the original. It has some of the better cross neutralization for some of these other variants. It's not perfect, of course, against these new variants, but it does have broader coverage. So I wouldn't say it's a pan coronavirus, but it is a little bit broader of a coverage of different variants. But I don't know how much protection this will give you into the future. And also, most people aren't eligible because it's technically a primary series vaccine. It's not authorized as a booster per se. Boosters are only authorized right now for the bivalent. But if you can get it somehow, it could be actually a nice mix and match option for those. And vaccines.gov does have a Novavax search engine right now for those pharmacies with Novavax.
All right. Thanks, Eric. Did you want to comment at all about your reaction to the president's statement that the pandemic is not over, or anything else fresh on your mind this evening?
Yeah, I've obviously many of us are very upset and frustrated about that comment, and it's also uncharacteristic of Biden because, in certain ways, if you think about Biden, he's like the empathy in chief, right? He's the one who hugs victims' families after mass shootings, after many other tragedies. He's an advocate for those with cancer. Launching Cancer Moonshot and everything. So he should be generally, an advocate for the immunocompromised and vulnerable. So this was kind of like uncharacteristic and unbecoming of him to say it. So I feel like it's a very political statement. They're trying to project normalcy, normality, and I think it's unfortunate because, again, in the world of political communication and optics, the CDC can say, for example, oh, hospitals and nursing homes in high risk areas only need to mask. The rest of the country doesn't need to mask. But then the rest of the anti-maskers or non-precautionary people will hear CDC says we don't need to a mask, right? And similarly, he can say, oh, COVID is still a problem, but the pandemic's over. No, the side comments are never remembered. It's the pandemic is over snippet that is talked about. And of course, I talked to some in the White House, and they're obviously very frustrated, and they keep saying, this everything's normal, nothing's changed, everything's normal, nothing's changed. But it's very sad that only 4% of America right now has even gotten the bivalent booster. Basically, there's no booster campaign, and they're worried that this pandemic is over message is only going to further weaken the booster rollout, because overall, like only 30% of Americans are boosted with any booster, and with the bivalent booster, which we need for this upcoming winter, only 4% of Americans have gotten it, and that's just abysmally low. And I think this public health messaging is really awkward, and it's only going to entrench the anti-vaxxers and and basically the minimizers. And so I think this is setting us up for a pretty dark winter, unfortunately. And I hope he comes around and is much more adamant about the messaging, because I think it's only Europe is already seeing a surge right now across Europe. UK hospitals are also increasing. Continental Europe, Germany is seeing double digit, like 50% surges in cases. It's only a matter of time before US sees it too, because we're already seeing the inflection point turning. So I think we're in a bad shape for what's coming in this winter.
Thank you. Thank you, Eric. So we have Dr. Benjamin Mateus that's been waiting. You can go ahead with your question. Thanks.
Thank you for having me. I'm a physician and writer for the World Socialist website. And again, I wanted to thank Dr. Al-Ali for his reporting on long COVID and extremely important pieces. My question, is to Dr. Al-Ali. Specifically, you work, in a very important area where you have access to integrated health, and you have access to a lot of information with regards to excess deaths from COVID or in this period of time, and as well as the cost to the healthcare system. I think one of the important things that you said in your recent paper on the neurological outcomes is the not only life, quality of life, but as well as the health system burden, as well as the socioeconomic and being able to earn an income will be dramatically affected. Are you looking at those factors as well as the medical part? And the second part of the question is, have the SARS and MERS and other viruses that cause post-acute viral syndrome, do they help inform how long COVID will stay with people and its impact?
Well, thank you, Benjamin, for this. Really, the very important two questions there. So first of all, it's really definitely on the same page there that the long-term manifestations of COVID-19 will not only affect people's lives. I mean, like for individual people, that they're, for some of them, their lives will be upended or have been upended by having a stroke or having new onset heart failure or other manifestations. But because of the colossal scale of the pandemic, and even though in our reporting there are single-digit percentages, almost all the time single-digit percentages, but those will translate into literally millions of affected people in the U.S. and around the world, and that will certainly have an impact on a rise in the burden of non-communicable diseases. So when we say like there's increased risk of cardiovascular disease and cerebrovascular disorders and neurologic disorders, et cetera. So those will add in to really the burden of the non-communicable disease in the U.S. and in the world. It will certainly impact health systems and healthcare costs, et cetera, and also economic productivity. Some of these people are some of the patients are not able to either lost their jobs, not able to work anymore, not able to be fully productive anymore in the economy. And because again, this is not only one or two people, because of the the scale of the problem, it certainly will affect economic productivity, labor participation, will have an impact on life expectancy. So we think that sort of the to tally up the both the direct and indirect cost of the pandemic will certainly require a whole lot more work over the next several years to sort of gain a deeper understanding, a more complete picture of all of these ramifications and their influence on these big metrics, sort of burden of disease, life expectancy, economic productivity, et cetera. And sorry, but again, what was the second part of the question? So that was your first part.
Sorry, yes. So I mean, we know that other viruses like SARS, we've had coronavirus pandemics that cause post-acute viral syndromes. And I remember reading some articles where the disease was manifest still 4 years out when they were looking at them.
Yeah, this is really absolutely wonderful. If there is a silver lining in this pandemic, is really it's a historic opportunity to really understand the post-viral condition. And sort of specifically here the post-acute sequela of SARS-CoV-2 infection. And I think that really will teach us a lot, not only about SARS-CoV-2 but more broadly about the post-viral condition. And unfortunately, to your question, there have been some work previously done, but not enough to sort of characterize the post-acute sequela of prior MERS and prior SARS and even the flu, but not enough, not to the extent that's really that we think they should have been taken seriously, but they were not taken very seriously. Remember, like even 100 years ago, people came down with encephalitis lethargica, new onset Parkinsonism after the flu, after the Spanish flu, more than 100 years ago. But people at that point ignored it and brushed it under the carpet and moved on. Had we paid attention then to the idea or the fact that viruses in some cases can actually produce long-term neurologic and other manifestations, we would be better prepared now. And I think to your question, I don't think there was enough research done, and I don't think this was taken seriously previously or seriously enough to really give us sort of more detailed information. And I think we really should make up for lost time and really leverage this bad situation. It's called a pandemic, and find a silver lining and try to advance our understanding of post-viral condition. And as Dana pointed out, we may not even call it the post-viral condition because maybe it's not post-viral if the virus is actually persisting. We're all saying here is that we really need to leverage the silver lining now to really better understand how viruses can lead to long-term sequelae or long-term consequences, not only to tackle the problem of long COVID, but to really better understand ECFS, chronic fatigue syndrome, better understand other post-viral conditions that happened previously, and really most importantly also help us deal with the next pandemic. Guess what? I mean, I have bad news for all of us. This is not the first pandemic that hits Earth. It won't be the last one. There will be another one. We don't know when, but I think we would be better prepared for the next one if we take this one seriously and really understand how and why viruses produce these things. So when the next virus hits in 10 years, 20 years, 100 years, or next pandemic hits, we're better prepared to deal with the aftermath. Right? Like you don't want to keep having earthquakes and ignoring the after effects of an earthquake. So when a new one comes, you don't know how to deal with the aftermath. We need to understand how to deal with the aftermath of an earthquake, right? We need to understand how to best deal with the aftermath of a pandemic in the form of understanding the post-viral illness. And thank you for Benjamin for both questions. Really amazing. Thank you.
Well, thank you so much, and really, I applaud your work. I appreciate it. Thank you.
Thank you.
Thanks for your question, Dr. Benjamin. Well, Eric, I've been following your Twitter feed, surprise, and I've noticed that you had some interesting posts about correctly swabbing. There's been debate amongst my own family and friends regarding the best way to take an at-home test. So do you want to talk about that for a moment?
Yeah, I think this was like an early discussion during the Omicron era, back in January of last year, late December, early January too. Basically, the current FDA's EUA for these swabs is technically just a nasopharyngeal swab. And first of all, let's be honest, many places don't swab the nasopharynx; they swab the nares, basically the front of your nose. Basically, swab your nose hairs, but nothing else. So, first of all, I think the nasal pharynx, if you do a home test, how many people actually go deep enough into the nasal pharynx, right? And second of all, there's a lot of evidence that you should also swab your throat and or your cheeks. So that was a debate. Should you do a saliva swab as well, and of your cheeks or your tongue or your throat? And there are studies that shows if you swab your throat or cheek in addition to your nose, like use the same swab, you do your mouth first and then you do your nose, that you would sometimes find more cases like a day or two earlier. And this was a study, and this has been reported on in January of earlier this year. But the new kind of thing a lot of people have been finding is that what if you do all three, as in your nasal pharynx, and you hold it there for 10 seconds, and before you do your throat, back of your throat, the roof of your mouth, back of your throat, as well as the cheeks, like basically the gaps around your mouth. So if you do all three, not just two, but if you do all three and also hold it in your nasal pharynx for 10 seconds, you can find more virus. And in certain ways, we have previous experiments that do show you will find more that way. So, I was trying to advocate that we should really up our swabbing, because in other countries, they do swab to both the mouth and the nose. And for example, Ontario's guidance teaches you how to not just swab your nasal pharynx, but also your cheeks and your throat. But we have guidelines for those in other countries, but we don't have that in the United States. And it's really frustrating. There's other things I'm frustrated about, for example, that, the CDC has refused to reclassify the definition of fully vaccinated, quote unquote, to include at least one booster, not to mention the new booster, but at least one booster, but they haven't done that. But like this is an actual scientific thing, because no testing, no pandemic, right? And testing is of course the problem early on. But it's not just the testing. If you want to do testing, you have to do it right. Because in many ways, if you just do a cursory job, you're not going to find it. And for those minimizers and oh great, I did a crappy swab and I'm negative, great. Even though I have a horrible cough, I'm still going to go to work or go to school. And I think, that just hurts. Now, everyone, you can't convince everyone to do this, but for those who do care, who are trying to protect our families, and I think many of us are here, listening here, I think you should do all the above, all three, and as well as hold it in your nasal pharynx for maybe 10 seconds. Now, this is not FDA EUA. This is not medical advice per se officially, but this is my personal opinion, because there's a lot of evidence that swabbing at least 2 out of 3, there's scientific studies that should have.
And their influence on these big metrics, sort of burden of disease, life expectancy, economic productivity, et cetera, et cetera. And sorry, but again, what was the second part of the question? So that was your first part.
Sorry, yes. So, I mean, we know that other viruses like SARS, we've had coronavirus pandemics that cause post-acute viral syndromes. And I remember reading some articles where the disease was manifest still 4 years out when they were looking at them.
Yeah, this is really absolutely wonderful. If there is a silver lining in this pandemic, is really it's a historic opportunity to really understand the post-viral condition. And sort of specifically here the post-acute sequel of SARS-CoV-2 infection. And I think that really will teach us a lot, not only about SARS-CoV-2 but more broadly about the post-viral condition. And unfortunately, to your question, there have been some work previously done, but not enough to sort of characterize the post-acute sequela of prior MERS and prior SARS and even the flu, but not enough, not to the extent that's really that we think they should have been taken seriously, but they were not taken very seriously. Remember, like even 100 years ago, people came down with encephalitis lethargica, new onset Parkinsonism after the flu, after the Spanish flu, more than 100 years ago. But people at that point ignored it and it's like brushed it under the carpet and moved on. Had we paid attention then to the idea or the fact that viruses in some cases can actually produce long-term neurologic and other manifestations, we would be better prepared now. And I think to your question, I don't think there was enough research done, and I don't think this was taken seriously previously or enough, seriously enough to really give us like sort of more detailed information. And I think we really should make up for lost time and really leverage this bad situation. It's called pandemic, and find a silver lining, try to advance our understanding of post-viral condition. And as Dana pointed out, we may not even call it the post-viral condition because maybe it's not post-viral if the virus actually persisting. We're all saying here is that we really need to leverage the silver lining now to really better understand how viruses can lead to long-term sequelae or long-term consequences, not only to tackle the problem of long COVID, but to really, better understand ECFS, chronic fatigue syndrome, better understand other post-viral conditions, that happened previously, and really most importantly, also help us deal with the next pandemic. Guess what? I mean, I have bad news for all of us. This is not the first pandemic that hits Earth. It won't be the last one. There will be another one. We don't know when, but I think we would be better prepared for the next one if we take this one seriously and really understand how and why viruses produce these things. So when the next virus hits in 10 years, 20 years, 100 years, or next pandemic hits, we're better prepared to deal with the aftermath. Right? Like you don't want to keep having earthquakes and ignoring the after effects of an earthquake. So when a new one comes, you don't know how to deal with aftermath. We need to understand how to deal with the aftermath of an earthquake, right? We need to understand how to best deal with the aftermath of a pandemic in the form of understanding the post-viral illness. And to thank you for Benjamin for both questions. Really amazing. Thank you.
Well, thank you so much, and really, I applaud your work. I appreciate it. Thank you.
Thank you.
Thanks for your question, Dr. Benjamin. Well, Eric, I've been following your Twitter feed, surprise, and I've noticed that you had some interesting posts about correctly swabbing. There's been debate amongst my own family and friends regarding the best way to take an at-home test. So do you want to talk about that for a moment?
Yeah, I think this was like an early discussion during the Omicron era back in January of last year, late December, early January too. Basically, the current FDA's EUA for these swabs is technically just a nasopharyngeal swab. And first of all, let's be honest, many places don't swab the nasopharynx. They swab the nares, basically the front of your nose. Basically swab your nose hairs, but nothing else. So, first of all, I think the nasal pharynx, if you do a home test, how many people actually go deep enough into the nasal pharynx, right? And second of all, there's a lot of evidence that you should also swab your throat and or your cheeks. So that was a debate. Should you do a saliva swab as well, and of your cheeks or your tongue or your throat? And there are studies that shows if you swab your throat or cheek in addition to your nose, like use the same swab, you do your mouth first and then you do your nose, that you would sometimes find more cases like a day or two earlier. And this was a study, and this has been reported on in January of earlier this year. But the new kind of thing a lot of people have been finding is that what if you do all three, as in your nasal pharynx, and you hold it there for 10 seconds, and before you do your throat, back of your throat, the roof of your mouth, back of your throat, as well as the cheeks, like basically the gaps around your mouth. So if you do all three, not just two, but if you do all three and also hold it in your nasal pharynx for 10 seconds, you can find more virus. And in certain ways, we have previous experiments that do show you will find more that way. So I was trying to advocate that we should really up our swabbing, because in other countries, they do swab to both the mouth and the nose. And for example, Ontario's guidance teaches you how to not just swab your nasopharynx, but also your cheeks and your throat. But we have guidelines for those in other countries, but we don't have that in the United States. And it's really frustrating. There's other things I'm frustrated about, for example, that, the CDC has refused to reclassify the definition of fully vaccinated, quote unquote, to include at least one booster, not to mention the new booster, but at least one booster, but they haven't done that. But like this is an actual scientific thing because, no testing, no pandemic, right? And testing is, of course, the problem early on. But it's not just the testing. If you want to do testing, you have to do it right. Because in many ways, if you just do a cursory job, you're not going to find it. And for those minimizers and, oh, great, I did a crappy swab and I'm negative. Great. Even though I have a horrible cough, I'm still going to go to work or go to school. And I think, that just hurts. Now, everyone, you can't convince everyone to do this, but for those who do care, who are trying to protect our families, and I think many of us are here, listening here, I think you should do all the above, all three, and as well as hold it in your nasopharynx for maybe 10 seconds. Now, this is not FDA EUA. This is not medical advice per se officially, but this is my personal opinion because there's a lot of evidence that swabbing at least 2 out of 3, there's scientific studies that shows that you can find more virus earlier on a rapid test. And this should have been discussion since January, but it's kind of died out since then. I just wanted to re-up that kind of conversation and that awareness, especially heading into winter.
Yeah, I appreciate you going through all that, and I'm sure our listeners do as well. So thank you, Eric, for that. We've had a couple of people patiently waiting. Daniel, would you like to go ahead with your question?
Yeah, and to be honest, it's really not a question. It's more of a commentary. Fortunately, I've been able to sit on Vanderbilt's HIV/AIDS clinical trial group, and it's hard for me not to think about what Robert Gallo and Michael Gottlieb must have been saying when they were trying to create an HIV vaccine. And I'm sure they would be saying the same thing we're doing right now. Hey, we're doing a lot of viral evolution, and we can't create a vaccine. We still don't have one for HIV. And so what transformed HIV were 3 things. Number 1, PEP.
Oh, Daniel, we have to wrap up. If you do have a question, we would love to take your question.
Well, it was, for the doctor. One of the things, because of my knowledge, I was going to bring up a few things, and that is a point-of-care viral test. I don't know if one's been created. There'll also need to be a resistance test because Paxlovid rebound is virologic failure. And the other thing that I think is very important for everyone to consider is that there is a minimum EGFR or kidney function that is required by antivirals. And I don't know if anybody in charge of anything with antivirals has given that any consideration whatsoever. You can repurpose antivirals all day long, but if the people out here that you're supposed to be taking care of, if their kidneys and their liver can't support it, you might as well just down the commode because that's how valuable it is.
All right. Would anyone like to comment on that? Thanks, Daniel, for calling in.
I think he's bringing up an important point. So most of the antivirals that we have right now have not been tried or evaluated in randomized controlled trials in people who have kidney disease, for example. I mean, bringing up like if you have kidney disease or liver disease, you may not be able to get Paxlovid, right? And I think that's really an important point that we often sort of often whenever pharmaceuticals are developed and they're tried in randomized controlled trials, the inclusion and exclusion criteria in some cases exclude people who have kidney disease or advanced liver failure or advanced liver disease, and there need to be consideration for those folks as well. So definitely agree in that department.
Great, thanks. Jill, would you like to go ahead with your question, and then we'll move to Nora. Jill, you're off mute, but we can't hear you. Nora, would you like to go ahead?
Hi, thank you. So Dr. Feigelding, I have a question about the swabbing, and I've actually been doing the throat and the nasal. And I appreciate that's because I've read some of the things you've written, and I'll add the cheek as well. But should one blow the nose a little bit before you do the swab in order to loosen the mucus? And then also, also just in general, in terms of talking about politics, I feel like our political leaders have failed us. So I was wondering if all of you guys could talk more about going another route, going more circuitous, and sort of reaching out to businesses and industries that might have more of a stake in this, because I feel like, and I voted for Biden, but I'm excessively disappointed. Just wondering what you think we can do to go around him, since going through him isn't working right now. Thank you.
Yeah, good question. So first of all, yes, in my thread, I'd written that you should blow your nose and you should avoid drinking water for 30 minutes before you do any throat or cheek test. That's the official guidance from the Ontario Public Health Department. So you should definitely do those things if you do any of these tests. So, but where's the CDC on this, right? Like, all these other governments, and it's not just Canada. Other countries do mouth and nose as well. But where are these? I go. If you go to some of these other places, they really stab the nasopharynx test really far back. But many rapid test places here, they just do the front nose and that's it. The guidelines are very loosey here, and there's not much guidelines for beyond just the nasal swab. I think that FDA needs to update their EUA on this, but it's been completely dropped in many ways. Obviously, we have a lot of frustration against the CDC for many things lately. Dropping masks, using the stupid community levels map for guidance instead of the transmission map for guidance. That's kind of ridiculous. Biden obviously has much on his plate. I think, he's been advised poorly, in my opinion, in many ways. And I think, there is this People CDC movement. I'm not intricately familiar with. I'm not involved with the People CDC movement. But in many ways, we at the World Health Network, we're trying to put out guidance. Ahead of the game. For example, the monkeypox, we declared the pandemic emergency ahead of the WHO and ahead of the US by over a month. And the vaccine, by the way, we haven't talked about monkeypox in a while, but the latest study from real world study, so it's not like randomized trial, but real world study of those who are eligible for the monkeypox vaccine and got it versus eligible but didn't get it, there was a 14x fold lower risk of symptomatic infection of monkeypox. And 14x translates to an efficacy or effectiveness of 93%, which is really good. It's really good. And obviously, it's not randomized trial per se. It's a real world epi study. And we don't know what other behavioral changes there were after you were vaccinated, because in certain ways, those who vaccinate early could be more cautious, like many of us are, or those who vaccinate early could then become more promiscuous afterwards. We don't know. We don't know a lot of these other things, but it's a very interesting study, and 93% obviously shows that it seems to be pretty large. Whether it's actually higher or lower, we're not fully sure. But there's very little press release on this. It was CNN that actually got the scoop on this story. Where's the MMWR? Where's the CDC announcements on these things in addition? And so I think in many ways, I think part of the fault is that there's so much there. It's like a fire hose of information, and the CDC has only its bottleneck is probably at the top, I think, and the communications department is probably overloaded, and they're trying to decide what to translate in the policy and what to make a deal. And I think that they have really dropped the ball. And as that CDC internal audit has shown, CDC has really dropped the ball in its communication. But has it really done anything in reform? It says basically they're reforming everything except the top. Now I feel like we do need to reform something at the top, but that's only at the whim of the president or the whim of the director herself, whether she wants to stay on or not. And so I think there's no real accountability there, and we can just hope and pray. And hope and pray obviously has not really helped us after a year and a half with the current leadership. I don't know what the exact answer is. I pray that we get more congressional funding, but it doesn't look like it, especially after Biden's comment of, are we going to get $10 billion for a pandemic that if they say it's over? There hasn't been much appetite. And I hate to say this, but we're such a reactionary society that we only act after poop hits the fan, right? And I'll just say, unless shit hits the fan again this winter, we're not going to see momentum around COVID. Unless shit hits the fan with monkeypox, we're not getting any real action beyond just rolling out the vaccines, which, again, there's no real vaccine funding campaign. And, we've really cannibalized a lot of our funding for these bivalent vaccines. We bought 170 million doses, but is half of America going to take these bivalent? Right now, it's been out for a month, less than a month, but like in the last 3 weeks, the rollout has been horrible. The uptake has been very, very poor. And so this is why, this winter, when shit is inevitably, it's going to shit the fan somehow, then we're going to get a reaction, and maybe we'll get some policy changes. But I don't see any FDA changing the guidelines on swabbing, the definition of fully vaccinated. Only, like, by the way, only I think 30% of children have even gotten 2 shots among 5 to 11-year-olds. 5 to 11-year-olds, only 20, I think only around 30%, 1/3 have gotten 2 shots. And the booster is available too, but they haven't gotten it. Now, there's a new booster for kids coming out for age 5 to 11, hopefully by mid-October. But are people going to take it? No. That's the problem, that we have such a minimizing attitude, and leadership really makes a difference in terms of getting people galvanized to get boosters and to wear masks and to do testing. And right now we're doing much free testing much anymore, and we've stopped the mail testing by mail either. So I think we're in a world of hurt. I think we're in a worse stage than we were in the winter of 2021, because at least in winter of 2021, everyone was still cautious, right? And at least last year, people saw the devastation of the Omicron wave, which, rivaled the Delta variant wave and was worse. But I don't have immediate solutions. And this is the frustration right now, that I feel like we have to kind of organize ourselves into a precautionary movement. And I think getting unions involved, whether it's workers' unions like teachers' unions or SCIU and advocacy, I think there needs to be a wing of the progressive movement that pushes for these changes, and just hope and pray that the rest of society will come along, when they are proven right. And I think that's the world we live in right now, that if the government's not going to do it, we have to build a movement, grassroots ourselves. So I hope we will build email lists and movement lists that can help further this.
Yeah, absolutely, Eric. Earlier in the call, I had invited everyone to join the World Health Network. Wherever you are, whatever you do, whatever your background is, you are absolutely welcome and needed. We are trying to get as large numbers together so we can make our voices heard. Luckily, there's still some flecks of hope. I just saw Eric posted bring back masks was trending 10,000. I mean, when I see things like that, I do get a little bit hopeful that there are still plenty of people. We just all need to kind of get in the same place. And so we are working on that. And I welcome everyone to join us. It's www.worldhealthnetwork.global. Right on the homepage, there's a join us button. Someone will get back to you from our group, and we can get this moving forward. We're going to try to take one last question here from Chelsea. I know you tried to talk earlier. Hopefully your mic is working.
Hi, I think you're speaking to me. It's Chelsea with SH. Hi, I'm so glad to be part of your conversation. I don't really have a question. I just want to put this out there. I'm a mother of a 7-year-old type 1 diabetic, and I've been following Dr. Eric Feigelding for quite a while now, since I think 2020. My husband is a PhD physicist. He used to be a medical professor. I majored in fashion design in LA. And now I want to go into public health, and I want to kick some ass. Okay, can I say ass on here?
Yes.
We have been through the freaking ringer these past 2.5 years. And I want to say F off to anybody who doesn't want to protect their neighbor, their kids, their students in their classrooms. If a healthcare worker and they refuse to wear a mask, like my daughter's newly hired LVN, who is nice, but not that bright. People aren't following the science. It drives me freaking nuts. Okay, I gotta let this out because therapy hasn't helped the past year and a half. Therapy is not cutting it. Until this pandemic is truly over, as in 0 deaths from COVID, and not this falsifying reports bullcrap that we've been seeing, not this failure to do sufficient genetic sequencing to detect further variants within any country, given America has the worst freaking healthcare in a first world country. You know, my daughter needs insulin to live. And then you look at all these reports on Nature and Science and the Lancet and NIH. There's so many studies since late 2021 how COVID triggers diabetes. Like, how do people not freaking realize this? And then you want to, this is in no, I'm not throwing shade at people who have long COVID now. Like, I feel that. But look, we've been saying this. Like, I'm representing everybody who has a chronic illness before this freaking real pandemic. When I say this, we warned you guys. Like, we warned everybody we could in March 2020. We locked down. I pulled my child, my 5-year-old T1D child, out of school in March 2020 when we heard what was going on in mainland China. We have family in China. My husband is from Shanghai. They work in all parts of Shanghai, including the military. I shouldn't even be saying that because they will, it's crazy. But the point being is,
Thank you. And I hope that you join the network.
yeah,
Chelsea, have you found our join us button on our website? It's right there on the homepage. And I want to just say thank you so much for your comments and your passion. We have a place for you in our community. And I'd like to say thanks so much to all the speakers for taking their time to come out on their evening to talk with us and to give the right information. And I hope that I see you at a World Health Network meeting soon. Thank you so much, everyone, and good night.
Thank you. Good night.
Thank you.
Thanks, everyone.
Thank you.
Thank you.